Hi, I'm Bev Chapman, and I'm going to be doing a PowerPoint on renal failure. How do I get to the next? Do I press this?
No. I mean,
How do I
you can
get to
hit
the next one?
The space
You
bar.
can hit the space bar on the, that's
Wow.
probably easiest.
Or the down arrow. If that doesn't work.
Technical difficulties, sorry.
Mhm.
Okay, so to understand our objectives are to understand kidney function, why do our kidneys fail, dialysis, differentiating between the two types of dialysis, and the relationship of renal failure and dialysis. Okay, this is an picture of the kidney's anatomy. It's like if you would split it in half, you would see the calyces, the renal artery, and the renal pelvic. Wow, can I start over?
Just continue.
Oh, wow. Okay, y'all, I'm sorry. Okay, so the etiology of the kidneys, acute renal failure there's three parts to it. Pre-renal, intrarenal, and post-renal. And it can occur when there's any interruption within the renal function. Glomerular nephritis. By the time a person would discover that they had symptoms, then it's already too late, it's irreversible. Pyelonephritis is caused by bacterial infection of the kidney, and chronic urinary tract infection, UTIs, are inflammations of the bladder. Polycystic kidney disease, we'll talk about that on a later slide. Okay, acute renal failure. In the pre-renal failure, it's a decrease in renal blood flow. Intra-renal failure, there's structural damage within the kidney. And post-renal failure is obstructing the urine flow. Okay, polycystic kidneys. You see these little things on the kidney? Right now, they're cysts. And it's inherited kidney disease, and it forces the kidneys to enlarge, compressing them and replacing function. So, and this is not a good thing, because if you're to the point where okay, if they take over your kidneys, slow down the renal function, then you would have to have a transplant or hemodialysis. Otherwise, it's fatal, and the period is like 4 years. And I thought that I would put this up because people said diabetes do a lot of damage, and it seems to go hand in hand with other comorbidities. So on this kidney right here, it looks like it's scarred, but I don't know. But the normal kidney looks nice and smooth. The renal system consists of the ureters, the bladder, and the kidneys and the urethra. The kidney maintains fluid balance, formation of urine, and it regulates your blood pressure. Of course, the kidneys eliminates toxins, filters your blood, and like I said, it rids our bodies of waste in a soluble form through our urine. And it does this 24/7. The synthesis of vitamin D2 and vitamin D3 is vital to building bone. This is done by raising calcium and phosphate levels, promoting mineralization of the osteoid in the bone. So through a series of hydroxylation via enzymes, liver, and the kidneys. 25-hydroxycholine calciferol ends up becoming 1A hydroxylase, which is an enzyme that further breaks things down, make it easier to get into the bone. Okay, I have a short video on elimination. As soon as I figure out where to click it, I'm sorry you guys, I don't see.
There's a play button on the bottom right.
Yeah.
On the bottom right?
On the slide.
Let's see, did I get it?
It's right above the orange circle.
Oh. Thank
The
you.
it's a megaphone, like it looks like a megaphone.
It's there somewhere. I just don't know how to bring the picture.
Double
You
click
don't
it.
have to bring a picture. The picture doesn't.
Did I just click it out? I just saw something, y'all. Oh, I think this is it coming up, right? Yes, thank you. It's just a video short. It's showing
Turn up-
how.
Turn up the volume. Remember how we turned it down?
Uh-huh.
So turn it up. Yep. Move that slider. Yes.
Okay.
Or maybe it doesn't have any.
Can I probably could stop it and put it towards the, oh, I don't know.
So on that, yes, on that megaphone, right there. Okay.
Am I getting, okay, hold on there. Can you guys hear it?
Can you hear it?
No. Can we do anything with these speakers?
It's carried out of the body in urine.
Do you want to start over?
If the kidneys are unable to do this, and the condition is untreated, serious health problems result, with eventual loss of.
Okay, I'm sitting.
Okay, take that all the way back. There you go.
Okay, I got
Okay.
it.
Yes, and click that triangle.
Of the kidneys is to clean the blood. As blood moves through the body, it picks up extra fluid, chemicals, and waste. The kidneys separate this material from the blood. It's carried out of the body in urine. If the kidneys are unable to do this, and the condition is untreated, serious health problems result, with eventual loss of life.
Alrighty then. Next one.
You can go to the next slide.
Okay.
There you go.
Okay. Chronic kidney disease, CKD, comes on gradual. You lose a decrease in function, and it occurs within 3 months or greater. In chronic kidney disease, patients are not aware of their condition. Acute kidney disease, sometimes it's called AKI, decrease in kidney function, and it occurs less than 3 months. I have this chart right here because you know every time you go to the doctor you see the glomerular filtration rate on it, and it says for people of color and then for other people. I never knew what it meant until I looked and saw this chart. So I said, next time I go, I'm gonna check out and see where I'm at. So, okay, so there's 2 types of dialysis. One is hemodialysis. It's where you're hooked up to an artificial kidney and the blood is cleansed through this kidney. You have to come in to a health center or a clinic to get that done. The second part is peritoneal dialysis, and it's dialyzed through the perineum, and they call these exchanges for both of them. So I think it's normally lasting 3 to 4 hours, and a person might have like 4 exchanges a day. So I thought giving you guys a look at what this looks like.
And that's on peritoneal dialysis.
This right here is hemodialysis.
Can you do peritoneal dialysis?
Yeah,
Yes.
I'm getting ready to go down there.
Okay.
So, and this is a dialyzer, just so you guys know how it's done. Another video short, peritoneal dialysis. And forewarned, this guy has an accent, so I hope you could understand what he's saying. And how did we get this going?
You can double click the picture.
Yeah.
Oh,
That's what you did last time. On the actual
On the
slide.
pic, this, yeah, the square with the slide. Yep.
here?
Mm-hmm.
Thank you guys so much.
Oh, of course.
I press
Click the arrow, yes.
Peritoneal dialysis provides a way to clean the blood for those with kidney failure by using the abdomen. The peritoneum is the lining inside the abdomen and it wraps around the gut and other internal organs. Dialysis fluid is put inside, which draws out waste product from the body. To get the dialysis fluid in and out, a tube is inserted which sits around the gut. This is the peritoneal dialysis catheter. The clean dialysis fluid fills the abdomen. The dwell is when it sits there, and during this time, waste products and water slowly get sucked out. The fluid is then drained out, ready to start again. Fluid is removed slowly. At every cycle, a small amount is taken off. The fluid taken off is called ultrafiltration and often shortened to UF. In this example, around 100 mL of UF is taken from the body in each cycle. After 4 cycles, 400 mL has been removed. There are 2 main types of PD: automated peritoneal dialysis, which uses a machine while asleep for about 10 hours per night. The machine drains and fills about once every hour. Manual PD is used in most parts of the world. Every 6 to 8 hours, the patient drains old fluid out, then fills with fresh fluid. This was a quick run-through of peritoneal dialysis. Thank you for listening.
Okay, so I click it. Oh, I go to the next slide.
Yes.
So what determines if someone's gonna have peritoneal dialysis or hemodialysis?
That's a good question. I think it's the way your body is prepared to take it, or the way the person wants to deal with it. Because you gotta understand, this is gonna be a life change for them. So do you wanna go into a clinic and get hemodialysis? Or do you wanna do your peritoneal dialysis at home? And then again, the shunt that they put in for the hemodialysis usually takes 3 months to heal. They do an end-to-end, oh God, what's the word? Anyhow, they take the vein, the artery, and they do an end-to-end, I can't think of the word. Anyhow,
The fistula, are you talking about?
that's how they're making the fistula, and it takes 3 months to, 3
Like a
months
grafting?
to mature. Yeah,
Mhm.
so
So it's
some people don't want that. I guess it's what your physician decides you should have.
Also, too, it's going to depend on, what stage of renal disease are you in, and what other comorbidities do you have? How skilled are you going to be? Do you have people to help you? Most people are not doing peritoneal dialysis.
Yeah.
They're going into,
That it's ongoing, so you have to do it daily at home, and then hemodialysis is 3 to 5 times a week.
right, and with hemodialysis, it's a whole lifestyle change. People will be there for like 4 hours getting dialyzed, and also they have to get there. Here's another thing about dialysis. There are nurses there are nurse aides there, but not all dialysis companies will help you if you have to toilet, will help you get in and out of your cars. That's not part of what their function is. They're there to hook you up, they're there to dialyze you, unhook you, and go home. So you really want to ask some questions. Do you have somebody, if you're not able to walk by yourself, Do you have somebody that will bring you there, sit you there with you? Is there going to be somebody to help you toilet if you need to toilet? The other thing is you're going 3 times a week, you know? So is that less disruptive? That's 12 hours, you know, of your life. Is that less disruptive than what something like peritoneal dialysis would be? You know, I don't know. And that's something you really have to talk with your docs. And again, you know, what are the other comorbidities? What stage of renal disease are you in?
Right. And I think it was internanastomosis. Did I say it right?
Mm-hmm.
Okay. I wasn't exactly sure. The one thing that I've noticed in doing the research, a lot of diabetes patients end up having to go through renal failure and ending up having dialysis. I know a guy who's younger than me.
Just shake your screen because there you go.
Okay, so moving on. So I think it's another picture to give you that visual of peritoneal dialysis. It doesn't have no sound or anything. Okay. So some labs that they may do on a patient that has renal failure is a creatinine clearance, a BUN, urinalysis, and urine culture, hemoglobin, hematocrit, a bladder scan, renal ultrasonography, and I guess that's it. Or they might order a different test. There's so much they could do for renal failure.
Can you back up to that screen again? So just the down and dirty, when you were a nurse looking at these labs, your creatinine, your BUN, your hemoglobin, hematocrit, look at those. Like if you have a physician that wants to know, that those are some of the 3 that he's really going to want to know. And okay, yes, in tests, you need to know like some of the labs. I'm not going to test you over that because you can always do like a right click on it and see, is this patient within a normal range for BUN? Also, in your lab report, it's going to say L for low, H for high. You're going to know some of that. You can right click to see, you know, what other information can I get about these particular lab values. So again, I'm not going to test you on them, but know that they are their great source in looking at renal functioning.
Okay. Some signs and symptoms are your skin is very dry, and the pruritus, the itching. I think they give people like a lot of creams and stuff to help them with that. Irregular heart rhythms, muscle weakness and seizures, lethargy and somnolence, and confusion. I think if I saw somebody with confusion or being lethargic or, you know, having seizures or something, that would alert me to take the next step.
Is this for acute kidney injury or chronic renal disease?
Well, you actually can take some of these out for both, but the acute one, I would think that would go with the confusion, seizures, and lethargy, you know.
Or if you have an abrupt change in functioning.
Oh, did I skip? No. Okay, this, I don't know if it could play. Oh wait, you guys said double click. So this guy, I usually don't like to watch these commercials like myself, but he does really good in differentiating between both hemodialysis and peritoneal dialysis. Oh Lord, there we go. Okay.
Hi, my name is Dr. Mike Evans, and this is a quick overview for people with kidneys that are failing. We need some insight into the treatment options, including the different types of dialysis, as well as how to know when it's time to start dialysis. So let's start with the Kidney 101. You know, we talk a lot about balance and health, and your kidneys are the superstar of balance, whether it's fluids, or body chemistries, or blood pressure. Our kidneys orchestrate with other major organs to keep this delicate equilibrium going 24/7. All of this while filtering out waste products created by our body's metabolism. So when your kidneys start to shut down, your body has a hard time keeping a balance. You might retain fluid or waste products, your potassium or sodium might become abnormal, your blood pressure might rise. This can all make you feel rotten and raise your risk for serious illness. So you need a new way to filter and balance your fluids and electrolytes, and this is where decisions about kidney transplant and dialysis come in. It takes quite a while to plan your transplant or dialysis though. Your doctor will usually start planning for this when your GFR, which stands for glomerular filtration rate, and test of your kidney is around 20. This is about the same as 20% kidney function. This doesn't mean you need to start dialysis though. Most people start dialysis when their GFR gets below 12 or so. Actually, doctors are moving away from starting dialysis based on just a number, since this led to people starting dialysis earlier. And when we look back, these people actually didn't seem to do any better. So now, new Canadian guidelines consider your numbers, but recommend starting dialysis when you begin developing symptoms of kidney failure, such as severe fatigue, nausea, decreased appetite, and shortness of breath. However, this symptom assessment can be tricky, especially if you have other illnesses going on. So you need to work with your kidney team and your nephrologist, the doctors that look after kidneys, to figure out the symptoms that will improve with dialysis. We want people to start thinking about their treatment options at least a year before they are going to need to start dialysis, as it takes at least 3 to 6 months to make dialysis happen. So let's consider your dialysis options. One option is actually do nothing. You may feel that because of where you are in life, that your best choice is actually to let your kidney failure run its course. We call this conservative care, and the goal is to preserve kidney function for as long as possible through diet and medications, but knowing that this will not stop the slow decline in the kidney function and will ultimately lead to death. Conservative care is often chosen by people with other medical conditions who are candidates for transplant and feel the burden and discomfort caused by dialysis outweigh the potential benefits. The next option is to get a new donated kidney, either from a living donor, a relative or a friend usually, or someone who has died suddenly, known as a deceased donor. Not everyone is a candidate for kidney transplant, so it's really important to find out if this is a treatment option for you. As far as the two types of kidneys, deceased donor kidneys are not available immediately. In fact, in Canada, about 20% of people on dialysis are waiting for deceased donor kidney transplant, and it usually takes on average about 5 to 8 years. If you can get a transplant, this is the best treatment option for most people, since you will live longer and better than on dialysis. So that's why it's important to think about the other type of kidney donor, getting a kidney from a living donor, usually a family member or friend. Kidneys from a living donor tend to last longer than those from a deceased donor, and the transplant can happen earlier, even before you start dialysis. That's why it's important for you to talk to family and friends about the possibility of them donating a kidney to you. This reminds me of my neighbor and friend, John Naberezny, who found out that the guy who rented out his basement needed a new kidney. And so he went out and got himself tested, and it turned out he was a match. So he donated his own kidney. Incredible. We need more people like John, and it's probably a lesson in altruism for all landlords, I suspect. Okay, I digress, but this leads us to our third option, dialysis. Dialysis is when we replace the function of the kidney using special equipment to clean the blood. There are two basic kinds of dialysis: hemodialysis, which happens outside the body, and peritoneal dialysis, which happens inside the body. Hemodialysis is when your blood is passed through an artificial kidney, which is called, of course, a dialyzer. You'll need to make some changes to your diet and drink less fluid. Hemodialysis is usually done for 4 hours, 3 times each week, and requires access to your blood, either through an intravenous line inserted in your neck or a fistula. A fistula is created surgically by connecting an artery and a vein in your arm. Now this can take 3 months to be ready for use, so it requires some planning. You should ask your doctor which is the right option for you. Occasionally hemodialysis is done at home, even sometimes at night while you're asleep, which frees up your days and your diet. But most of the time, when we were talking about HD, we were talking about you going to a clinic or a hospital to have it done. Peritoneal dialysis, or PD, is when the blood is cleaned through a lining in the inside of your abdomen called your peritoneum. With PD, we put a tube close to your belly button into the peritoneum and pour in a special solution called dialysate and leave it there for a few hours. The solution slowly sucks, the medical word is diffuses, the waste products out of your blood. You then drain the fluid back out through the tube and then fill up the peritoneum again. We call this an exchange, and it generally takes 20 to 30 minutes. There are 2 ways to do peritoneal dialysis. This has to do with the timing of the exchanges. So first we have continuous ambulatory peritoneal dialysis, or CAPD. Typically this means 4 exchanges that you perform yourself every day using bags of dialysis fluid. During the time between exchanges you can move about as normal. Secondly, we have APD, or automated peritoneal dialysis, where a machine that you set up just before going to bed does the exchanges for you at night for 7 to 10 hours while you are asleep. During the day you might have some fluid in your abdomen, but you are free to move about normal. Okay, so now you know about kidney failure, and if you want to do dialysis, the next task is picking which treatment you prefer. Well, let's start with some obvious reasons to have your dialysis done at the hospital. Doing dialysis at home requires an ability to self-manage and problem solve, and I suspect your aptitudes in this department are better than you think. And I also get that it can be scary for you or your loved ones to learn a new skill, especially if you're set in your ways. Having said that, I think there are some conditions that can make it hard to self-care reliably. So for example, alcohol or drug addiction or cognitive impairment, or maybe you have another medical condition, or you're just finding things very hard right now. These can all be especially challenging for you if you don't have a reliable helper. Some people who have had a lot of abdominal surgeries can't do peritoneal dialysis either. The next category are challenges that need some problem solving, but can usually be overcome. So you or your loved one may have limited vision or hearing, or maybe some learning problems or physical limitations and so on. Extra training, mentorship, and family support may be required. So for example, hearing disabled patients can use vibration alarms. Frail patients can have family members trained. There's mentorship from patients who have overcome the same barriers. Or in some places, a visiting nurse can help set up your dialysis cycler machine at night. Dialysis experts will often say that if you can manage an ATM bank machine or have the manual dexterity to button a shirt, you can manage home dialysis. Just like there are factors that make us think that dialysis in a clinic is likely the answer, there are factors that make us think that dialysis at home will be a better choice. For example, you might live far away from a dialysis clinic, or have a fear of needles, or you might not be happy following the fluid restriction or diet required for hemodialysis. All issues that can make peritoneal dialysis at home a better choice. Having said all that, I think the biggest reasons people pick home peritoneal dialysis are personal, with the number one reason being flexibility and control. People often pick home PD because they prefer to self-manage in the comfort of their own home, and they don't want to travel to the hospital 3 times a week. You may want to travel, you may care for others, and need to be around, or perhaps your work or school can't accommodate frequent absences. It is possible to travel with HD, but you'll need a hemodialysis clinic where you're going, and this might be expensive and limit your travel options. Another factor that might drive your choice is whether there's evidence that one type of dialysis is better in terms of health outcomes. Well, there's never been a definitive trial comparing peritoneal dialysis and in-center hemodialysis, so there's a bit of controversy, but most docs think that patients who are candidates for either type of dialysis will do just as well in either form in terms of survival and quality of life. I think the reality here is that patients do best when they're able to get the information ahead of time, come up with a plan, and pick the type of dialysis that fits with their lifestyle. If we exclude really sick people who would not be able to do home dialysis, studies tell us that most patients who receive comprehensive education about the different types of dialysis will choose home dialysis, usually peritoneal dialysis. Okay, let me summarize. There are 2 main treatments if you need dialysis. One is hemodialysis, where you typically go into a hospital or a clinic on a predictable schedule and are hooked up to a dialyzer for about 4 hours 3 times a week. And you need to make dietary changes. Some patients are trained to do their own hemodialysis at home. The second treatment is peritoneal dialysis at home, which can be done with 30-minute exchanges 4 times a day, or by setting up a machine at bedtime which automatically does the exchanges while you sleep. PD is portable, and you can take it with you if you need to travel or if you want to do it outside your home. Both these approaches require a procedure for access and some training, so if possible, it's important that you make this decision at least 3 to 6 months before you actually need dialysis. Both of them require you to keep an eye on your symptoms: severe fatigue, nausea, decreased appetite, and shortness of breath, since these will guide you and your kidney team to know when it's time to start dialysis. Failing kidneys is definitely a journey, and hopefully this overview, combined with discussions with expert patients, and people you trust, will make your journey more personalized. Hope this helps, and take care.
Okay, so some nursing diagnoses would be fluid volume deficit, risk of infection, ineffective renal tissue perfusion. Oops. And nursing intervention. These types of patients, you definitely gonna want daily weights, accurately monitor their intake and output, check blood pressure in both arms. I would think, unless they have a fistula, don't do that arm.
One thing you said, fluid volume deficit. What about fluid volume overload?
Yeah.
Since that is why they're having
the
dialysis.
Yeah. So you're probably right about that. Frequently assess urine specific gravity and the BUN, serum creatinine and protein levels. Maintain fluid and sodium levels. And some patients feel like they just have no appetite. So if you could find a pretty appetizing, high caloric meal to give them, bless you, that may be okay. And then monitoring the vital signs and reporting hypertension. I think when they have hypertension, something is going on. Because it could signify acute renal failure. And that is the end of my PowerPoint. Now, how do I stop it? Oh my God.
We could shut it down in just a second. Do you have any questions?
Yeah.
No.
I got it.
Okay.
I'm getting used to it a little bit.